Now I'd like to welcome to the stage our next speaker, Anum Ali Mohammed. Anum is a master's candidate in global medicine at USC Keck School of Medicine. She did her undergraduate studies in Middle Eastern Studies and Anthropology at Emory University in Atlanta. She has also conducted research in pharmacology, studied medieval Islamic studies, and has gone on 2 archaeological excavations. She also just started an internship at Mending Kids, one of the one of the organizations represented here today. So without further ado, I'd like to welcome Anum to the stage.
All right, hey kids. I found something out the other day. Apparently, being Muslim in America is bad for my health. So you're supposed to laugh at that, but whatever. My delivery wasn't good, I guess. So there's been recent research released that shows that increasing Islamophobic attitudes and discrimination against Muslims has actually led to health disparities in American Muslim communities. So I got started thinking about this issue, and I wanted to know how the current global political climate affects health on a global scale. So how does the current political climate, which exacerbates this historical, cultural and political clash between the West, the United States and Western Europe, and the Islamic world, and what implications does this have for global health? Particularly, I focused on one question. I wanted to see how international aid organizations approached Muslim communities in the developing world who were resistant to global aid initiatives, who were resistant to international vaccination campaigns and things like that. And so what I found, So what I found is that Islam acts as a barrier to the delivery of global health aid in 2 key ways. First, directly, when certain strategies or parts of global health strategies contradict directly with Islamic doctrine or Islamic ethics. Those barriers can be easily overcome by appropriate cultural competency training. So that's not what I'm going to focus on in this talk. But also, Islam acts as an indirect barrier to aid by promoting attitudes related to Muslim identity, specifically attitudes of negative perception towards the West and a negative perception towards international aid agencies, which are perceived as pushing Western agendas. So we see this fact reflected in the global polio eradication campaign. The last 3 countries that were strongholds of endemic polio virus, eradicating polio in those countries, Nigeria, Afghanistan, and Pakistan, targeting dissident Muslim groups was a key problem that global health programs had to overcome in eradicating polio in these areas. So we need to design a strategy that allows us to change attitudes that Muslim communities have about aid organizations that aren't even Western, but that are perceived as Western. And we need to propose new approaches for the successful deployment of health initiatives in these resistant communities. So I think this is important because so all of the countries highlighted on this map are low and low middle income countries. So these are the poorest countries in the developing world. And if you look at all of the stuff that's in the darker green, those are countries where half or more of the population is Muslim. So you see that a large percentage of the developing world is actually Muslim. It's about 37% or 1 billion people. So the majority of these Muslim communities in the developing world are receptive of global health aid and work well and collaborate with agencies like the World Health Organization and other UN agencies. But some of them do not cooperate. And as the Muslim population grows, and Muslims in these communities face key health challenges like high maternal mortality rates and emerging diseases like dengue, being able to address Muslim communities in which Islam acts as a barrier to aid is going to be an important strategy to have. So I've come up with 4 approaches for doing this. And they're all simple because simple is okay. This kept coming up in all the papers I read, so I put it in. The first is better cultural competency training. So the current model for cultural competency training that's used either promotes just learning about the theory of what cultural competency is, or it gives you a handout and a bunch of facts about a group of people and teaches you that you need to provide translators or be language proficient. I think it's more important to have community-focused cultural competency training that teaches you about the attitudes and values about communities and also about their social the social hierarchies present within them. By having better cultural competency training, especially at higher levels of project design, we'll be able to design more specific strategies for communities versus a one-size-fits-all that we have to then go back and edit and do trial and error to fix. Also, communicating with the community at all levels is another important approach. This approach was actually used to eradicate polio in Nigeria. Local communities were engaged, traditional leaders, religious clerics from Muslim communities, and also community members through the religious leaders. They would deliver sermons in mosques that had specific public health messages in them and would advocate for the safety and efficacy of polio vaccines. And that was a key strategy that was used in Nigeria to really eradicate polio there. Also, it's important to engage with communities of non-state actors, especially in Pakistan and Afghanistan, where polio is still endemic. Engaging with violent non-state actors like the Taliban is going to be integral to actually successfully completing polio eradication campaigns. I actually found a policy report from a nonprofit where they sent people on the ground to interview Taliban leaders. And they found that in order to effectively build trust and relationships with the Taliban, you have to communicate with the Taliban leadership structure at all levels. So usually when international aid organizations work, they'll communicate with like a government. They'll communicate at the government level, and then there's NGOs on the ground that deploy programs. But it's important for international health organizations to engage in talks with these non-state actors at the community level too, to build trust and convince them that they're not trying to push a Western agenda, that they're neutral agencies. Okay, also we need to increase transparency and follow-through. In the same interview with Taliban leaders, one of the key reasons that they gave for not welcoming vaccination campaigns into their territories was the lack of transparency in their goals and why they were there, who their stakeholders were, who they were funded by, and also lack of follow-through in efforts. Aid organizations would make empty promises to these communities. They would get excited, as anybody does, when people make promises to them, and there wouldn't be follow-through, and all the trust that they built would get lost. The fourth strategy for targeting Muslim communities who don't want global health programs to be delivered within their jurisdiction is to establish legitimacy by activating Muslim networks. I think it's a misconception that the Muslim community isn't connected, right? There's actually lots of ways that the Muslim community is. There's multinational organizations like the OIC and the Arab League that can put political pressures on a group. There's also diasporic communities. So there's Afghan Muslims in the UK and America that you can mobilize as advocates for the efforts of international aid organizations. Okay, so that's just a summary of the framework. And then in closing, the underlying factor in all of these strategies is that they're community-focused and work to build trust. And trust building and engaging in dialogue are really the only ways to combat health disparities created by cultural attitudes, especially ones with roots as deep as the clash between the West and the Islamic world.